And really, there can't be a more important time to have this conversation. As coronavirus sweeps the world, the fact that we are all connected to each other and that we need to learn across borders has never been more clear. And of course, within the US, the virus is exposing the cracks and vulnerabilities in our systems and heightening the inequities in our society. I mean, just ask the 60% of the US labor force that is paid hourly, how easy is it to take off in a moment of need? So as you can see, there's a lot to discuss, and I'm eager to dig in. But before we do, just a couple of quick reminders. First, everyone's audio has been muted, but you can ask questions at any time using the Q&A button on the bottom of your screen. We'll be having a Q&A section in the second half of the webinar. And finally, we're recording the webinar and we'll be sending it to you later. And now we wanted to learn a little more about all of you. There are two questions which you should see on your screen. Just click on your answers. The first one, and then scroll down to see the second one. The first question is, how are health equities showing up in your community? Just check all that apply. And then when you scroll down, you'll see the second question, which is, why did you join today's webinar? And again, please just check all that apply. We'll give people a couple minutes to respond. All right, last chance to get your answers in. And let's see if we can pull up some results now. All right, so here's some of the results. How are they showing up in your community? Wow, well, over 80% talked about homelessness and lack of access to health care. Discrimination is another big issue. As to why did you join today? Wow, it's an even split among the three choices. Wanting to know more about health equity, looking for solutions to bring to your own community, and want to understand what we can learn for other countries. That's great. So I hope everyone will find value in today's conversation. And I want to introduce our speakers and get the conversation started. But I thought I'd just take a minute to talk about what we mean when we say health equity. You know, I was recently in Tulsa, Oklahoma, and I had the opportunity to visit a regional food distribution center that was the size of an airplane hangar. I kid you not. You know, so on the one hand, it's incredible and fantastic that people have access to such a resource in times of need. But in a nation as wealthy as ours, it's also outrageous. Why are so many people dependent on food pantries? Why are so many people going without food in the first place? That's just one example of what health inequity looks like. It looks like hunger. So when we talk about health equity, we mean making sure that everyone has the basics to be healthy. This means we have to tackle the stubborn drivers behind inequity, like poverty and discrimination. And as you'll hear today, often those drivers include things that aren't even on our radars. When we understand the drivers, it opens up solutions, and we can begin to create opportunities for everyone to live the healthiest life possible. Just like in the US, countries around the world are grappling with how to do this. At RWJF, we want to understand what we can learn from their efforts. And so to that end, we supported the World Health Organization's Health Equity Status Report, which is called Healthy, Prosperous Lives for All. We're also supporting the Health Equity Network of the Americas, which is focused on implementing recommendations from the Pan American Health Organization's recent report, Just Societies, Health Equity, and Dignified Lives. Both of these undertakings demonstrate the power of data to catalyze action. So I'm eager to dig in with our two fantastic speakers today to explore how does measuring health equity and its drivers help to shift policy, and how does it help us to find solutions? So let me introduce them now. Christine Brown leads the World Health Organization's European Office for Investment for Health and Development. Chris spearheaded the development of the European Health Equity Status Report, which outlined policy actions for all 53 of their member states to advance health equity. Chris is joining us from Venice, where, as you all know, residents have been on lockdown. So we are really thankful to have her join us in this really challenging time. Dr. Michael Rodriguez is the founding director of the Health Equity Network of the Americas. It's a network of policymakers, researchers, and advocates working to advance health equity across the U.S. and other nations in the Americas. He's also a professor at UCLA's Department of Family Medicine and its Department of Community Health Sciences. So I'll kick things off by asking Chris and Michael a couple of questions, and then we'll turn it over to you, the audience, to ask some questions. So please, again, enter questions into the Q&A button at the bottom of your screens. So let's get started. Chris, you're looking at health equity across Europe, and Michael, of course, you're looking across the Americas. Can you each talk a little bit about what are the leading drivers of inequities in each region, and how are they similar or different to the U.S., and what surprised you about these drivers? Chris, if you want to start. And you'll need to unmute your
Thank you, Karabi. I'm delighted to be here. Yes, it's a very strange time, but this is such an important issue. I wouldn't have missed the opportunity to be part of this debate. In the European region, we have 53 member states, different political, economic situations, cultures, and yet we found that there were 5 drivers that are keeping people back in life from prosperity, well-being, and health. Some of the traditional ones, well, we'd expect in terms of financial insecurity. But here the surprise was, it's not the people that we're seeing on the streets. This is bad, but we're now seeing 10% of the people who just can't make ends meet to the end of the month. So this is a growing area. This surprised us, the kind of dimension. Poor quality housing, but within that, lack of neighborhood security and sense of safety. Access to healthcare, despite the fact that within Europe we have universal healthcare, we don't actually have it in practice. So we have the policies, but not the action. Lack of decent work, but the big surprise was, for us, was that 20% of all the inequities in between different social and economic and ethnic groups across the European region was due to lack of sense of trust, belonging, and poor access and quality of education. So trust, belonging, and sense of agency, sense of purpose in life was fundamental to all these other things. So this was very new for us and explains why some of our policies and interventions have not been working, because they have not been about creating agency and change with people.
Thanks so much. Michael, what is it looking like across the Americas?
Thank you so much. I appreciate the invitation to participate in this fantastic webinar. In spite of the gains in overall health in the Americas that have been substantive throughout the Americas, the health benefits are unequally distributed and major inequalities persist. In fact, these major inequalities are slowing health improvement and even reversing it in some cases, as shown by recent life expectancy decreases in the US. As was mentioned, the Pan American Health Organization's Commission on Equity and Health Inequalities launched a major report last October of 2019. And in their expert commission, they identified leading drivers of inequities, focusing on structural drivers such as political, social, cultural, and economic structures. Examples of that include the ways that markets operate that contribute to inequality and limit opportunities for many. Another category of structural factors are natural environment, land and climate change. And a third is history and legacy of ongoing colonialism and structural racism. The important concepts that were put forward and not found in similar international documentations is this emphasis on structural racism, colonialism, as well as the importance of the relationships to land. These have greater emphasis, as particularly because of the importance that we're learning about the environment and climate change, as well as the importance of a more explicit focus on human rights and greater emphasis on inequities according to gender, ethnicity, sexual orientation, life stage, and disability. This underscores the important role of how these structural drivers influence the conditions of daily life, such as the houses that children grow up in, the schools that children study in, jobs that people work at, systems to ensure living wages and social protections, all of which impact health.
Great. Thanks, Michael. With both of you, I know there's a variety of programs and policies that are being rolled out across both regions, with countries taking a number of different steps to close gaps and build more equitable communities. And I know there is so much that we can learn from all of these efforts, but if you had to pick just one thing that you think the U.S. could learn from Europe, for you, Chris, and from Latin America, Michael, about one thing that the U.S. could learn about advancing health equity, what would it be? And Chris, we'll start with you.
I'm going to be really cheeky. I'm going to maybe give you two if I can, but I'll make it quick. I think the first thing that we learned was that the gaps that we have cannot be shifted with a single intervention. So we are promoting a basket of policy interventions that have people at the center. So for shifting forward, even in countries who already have more equity, pro-equity policies, we're still finding that we think that we're going to shift these massive exposures to risk conditions with one single intervention or a short-term project. So the issue for the European region that I think we could share and we would like to learn from the States is how to have a basket of interventions that really level up the health for everybody in the population, but which accelerate that rate of leveling up for those who are being left behind. And we think that we can do this, and you can see here on this slide how we've been able to calculate with a basket of policies with a reasonable investment, a 0.1% GDP investment in these policies, how many lives would be improved, and this is within 4 years. So in a country of 4 million or a state of 4 million, it's 15,000 lives. 40 million, it's 150,000 lives, and 80 million, it's 300,000 lives. You say that to politicians, and there's no way that they can say, okay, it can't be achieved. So I want to also say that we need to use our data to be able to talk to the political constituencies that empower them, but also make it possible, the solutions to be implemented. So I think this is some of the things that I would say we could share as way of learning.
That's great. And I hope that when we come to questions from the audience that I think this issue of communicating the data in a powerful way, in a way that's within the term of a politician, that we might be able to come back to that. But Michael, tell us what you think. I mean, what are you seeing across the Americas in terms of policies and programs, and what is the one thing maybe that the U.S. might be able to learn from?
Well, it's it's a great question that you have, Krobi, and I have to say that kudos to Chris and that the observations that she's learned and sharing are also ones that apply to the Americas. In fact, one thing that is important is that there is no one thing. To underscore what Chris said, it is the variety of programs and policies that are being rolled out, and really, to some degree, it's an approach, and one of the really impressive things about that I'm seeing, particularly in Latin America, but in also other areas, is that we can learn from is that the value of learning from other neighboring countries, as well as municipalities within countries, what they're doing to promote health and wellness, and in a collaborative way. For example, the Pan American Health Organization works across countries in creating and supporting networks and collaborative efforts to build on what we know about social and environmental determinants, how they impact health, and how they're influenced by policies and actions of many sectors, including urban planning, transportation, housing, food environments, education, energy. And it really is in this spirit of connection. And as you were saying, Kirby, the communication between these different countries, sharing this knowledge is extremely powerful, and they've shown how it also can be mutually beneficial.
Can I just come back in there? Yeah, because I think there's one other thing that we learned, and I'm seeing some of the chat things that are coming up there. Some of the for us who are steeped in this, and I've been working in this area now for 35 years, and we take for granted that things like social determinants are understandable to people. What we're really talking about is having food on the table, feeling safe where we live, having an opportunity in life to earn a decent living, and to be occupied in decent employment. These are social determinants, but when you talk to people on the streets, social determinants doesn't mean anything to them. What they can talk about is their lives. And one of our big lessons learned, and I would be really interested to hear from those who were connected today, is that the reason why we're failing, and I use that word failing because we have got a lot of evidence, but we are failing to use it, is because our evidence is based upon, and our policies and decisions are made on some fictitious average person. And what we've learned is that to design interventions, multiple interventions that will level up the health of the whole population and accelerate the rate of those being left behind, we need to understand and have better evidence on the lived experience. And how do we understand? So let me give you an example of this. So in the UK, they have just scaled up a health justice partnership so that all primary healthcare settings have within them not only just the health practitioners, but they have people on site who are able to support people in terms of getting out of debt, managing arrears, preventing becoming homelessness. This started off in a small community where there was a lot of homelessness, and people were coming to the GP and saying, I've got stress, I've got anxiety. Not saying, I'm worried I'm going to lose my home, I've got an eviction order served on me, I haven't got enough money to feed the kids at the end of the month, I don't know whether to put electricity in for the cooking or to have, heat for the children in the room. These are the realities of people's lives, and we don't know this. We haven't taken that on board. This initiative used a social model of collecting data, looking at barrier assessment, ethnographic research using community-based approaches. Really fascinating. I can tell you that they have scaled this up to every single primary healthcare centre across the whole of England, and they are telling me that it is reducing the cost of the criminal justice system, it's improving mental health, and it's reducing demand on the health system. So this is an example for me about how we need to put some of these things together, baskets, people, determinants, but at the end of the day, we have to simplify our language, because one of the reasons we're not getting ahead is that we're not able to have conversations with other people about why it matters to them in their sector or their lives. I stop there, maybe.
Yeah,
no. Go ahead, Michael.
Just to add, I agree with what Chris is saying, that the importance of addressing what we're referring to as social determinants of health cannot be overstated. And it's a shift from looking at dealing with what's immediately around us to dealing with those things that influence our environments. What we sometimes say is the causes of the causes that result in the environments that we are in when we're born, where we play, where we go to school, where we work. Those type of things that really help to influence them. I mentioned them earlier as examples are political, social, cultural, and economic structures, the decisions that are made by our governments as examples that shape those situations. The more that we're focusing that in that way, and also focusing, acknowledging the role beyond the healthcare sector in doing this, the more we're able to impact on those larger processes that impact health so significantly.
Yeah. So there is a lot happening in the chat, and so I'm just going to ask you guys one last question, and then really open it up to the audience, because people are raring to go, which is fantastic. And this is really kind of picking up a little bit on what you were saying, Chris, about so a country example, right? And so you were talking about the UK. I don't know if there's an example beyond some of the usual suspects of a country that that maybe doesn't have a large track record on health equity, but is making progress all the same. And then, Michael, I'll have the same question for you.
Yeah, I mean, I could think of lots of unusual suspects, I might say, and what we see across our 53 member countries is peaks and ebbs in policies and who's leading and who isn't making progress. Let me give you a really good example. North Macedonia is a transition economy in the Western Balkans. 10 years ago, it was deep in civil war. There are still ethnic tensions. The economy is shot, and they have been able to scale up coverage of essential primary healthcare services. But what they're doing is they are now taking a place-based approach. So they have realized that they need to harness the Sustainable Development Goals, the need for inclusive societies and cohesive societies for prosperity and well-being for all. And they have developed a way of mapping with our information these 5 essential conditions and saying, how can we create a framework at the local level for people to engage around those 5 essential conditions, creating them, investing in them, whether they be public, private, NGOs, or the health sector. So that's one good example. Another example is a country, Hungary, which is a very large country in Central Europe. And they have been using a basket of policy approaches, using life course approach. They are looking at how do we build each life course so it's as healthy as it can be. And their investments in a basket of policies over the last 10 years have seen the most remarkable reduction in inequalities in child poverty and increase in the equity in child well-being in any country in Central Europe. They've been doing it quietly, and we should give them, all countries in Europe, obviously credit for what they're doing. But here are 2 examples.
That's fantastic. Yeah, really, really interesting. Michael, what countries come to mind for you? Sort of beyond, some of the wealthier countries, some of the unusual suspects.
Thank you. And if you didn't guess, I'm going to mention Costa Rica as one of them.
Yeah.
But besides Costa Rica, I do want to give a nod that there's a number of different countries aside from Chile and Argentina and Brazil, Costa Rica, Brazil. Colombia, Uruguay. In Costa Rica, one of the interesting things that they're doing is their national health plan. That dictates decisions made related to health of the country, of the population of Costa Rica, includes health equity as part of their mission. And it goes beyond that to incorporate measures to improve the determinants of health, such as access to nutritious food. What is it that influences safe water, improves sanitation, and also, interestingly and importantly, what are the actions that the health sector is taking to respond to climate change. Beyond that, they have implemented a comprehensive and expanded primary healthcare system that reaches over 93% of the population. Very powerful. More recently, I actually just communicated with the previous Minister of Health, Rocio Sanz, who was sharing with me the coordinated efforts that are going on right now to respond to the COVID-19 infections and help to contain it by having this coordinated multi-sector approach that sends a consistent message to the population and in order to effectively help to contain it. Other countries, such as Colombia, are moving forward and promoting healthy city initiatives. Medellin developed a monitoring system to show the positive impacts of addressing the social determinants in health outcomes. And in Paipa, Colombia, they have a human social network model. This is one that is people-centered, involves several sectors of the city working collaboratively to integrate a health in all policies approach.
That's great. That's great. So, for those of you who are logged in and have access to the chat, I encourage you to look at the chat, but also, and maybe more importantly, please add questions in the Q&A, and because we're going to try to respond to as many of those as we can. So one of the questions that came in was for you, Chris, which is focused on, so they say it would be helpful to learn more about the issues of trust, belonging, and agency. So for example, some details of how these concepts were identified, measured, and also whether trust, belonging, and agency are related to what in the States we typically call civic engagement.
They're really interesting questions. I will try. We in the European region have been advancing quite a lot of the evidence work around well-being and indicators of well-being. And what keeps coming out around well-being is issue a sense of belonging, social support, having someone to ask for help, feeling secure in your environment in terms of not being exposed to both domestic violence and violence in the community or harassment. And very much this sense of being able to take control of those problems in my life to solve them with the help, as well as to be able to achieve potential. And we used the European Social Survey. So what we did with the help of RWJ was we created a whole new big database, and we have 136 indicators, of which we have indicators of well-being, which include trust in others, social support, sense of belonging, agency. And these come from a range of sources, mainly the European Social Survey and other sources. that we've basically taken apart and put back together again to be able to, in a robust way, I should say, to be able to see how it looks in each country. Yes, some of it is around civic engagement, but it's more than that. It's what we're seeing is a lot more divisions where people live. We're seeing that this can be challenged by the way that local communities, town planners, architects, environmental agencies and health sector can come together with the private sector to design environments that are much more safe and inclusive and encourage people to interact. And that's the first thing. The other thing is that's quite a big thing in some of our transition economies is citizenship learning. So in schools, in kindergarten, citizenship, respecting diversity, respecting difference. And these are things that were on the curriculum 20 years ago. And it's almost like people think we don't need it now because we've got to this level, and we're saying, in fact, we do. So here's practical examples of how they're being applied and some of the reasons for it. But we just made a publication that we workshopped in October last year, which said, these things are so fundamental, and we are not building them into the design of services or interventions. We're not talking about them when we are looking at what kind of investments we need that will create prosperity for all in society. And we had a workshop with over 3,000 policymakers from all over Europe, the Gastein Forum. And we had a publication from that, which was about the role of agency and democracy in tackling inequalities. And here we're bringing in that civic participation is one, but if you don't have a local council or authority or whatever who wants to be engaged, that civic engagement will only take you some way. So the publication outlines both some of the other attributes that you need to have in place for that agency to be activated and useful for health equity, and lots of nice examples of how it's being done.
Great. Michael, did you want to chime in on that?
Yeah, yes. The other related aspect of this has to do with having to do with trust is another concept related to social connection, social cohesion, sometimes also referred to as social capital. They're all different things, but they overlap in terms of the connectedness in communities that bring people together, and for which trust is a really important basic element, and trust that that they all have an important commonalities in terms of their destiny, and that by working together, they're more likely to help each other to improve health and overall well-being. And so this is something that's been worked on in many different places throughout the Americas. And also, as I mentioned, I see here in the chat, is also used to help to engage against such examples such as the xenophobic sort of stigma that is being used around this COVID-19 virus, particularly around folks who may be of Chinese descent, and trying to proactively get ahead of it and bring the community together to show that that actually undermines our unity, and that it really is in working together that we are more effective at being able to improve health outcomes for all of the population.
Thank you. That's great. So another question that's come in, and maybe this is for both of you. How have you seen organizations play a role in tackling social determinants and in influencing policy changes? I don't know who wants to start. And by organizations, I'm guessing that might mean civil society, but it probably, that's my interpretation.
Sure, I can sort of give it a start, and Chris can sort of chime in afterwards, since she's an expert in this area as well. And, I have to say that this is really something that we haven't emphasized enough, I think, is the role of the community, ultimately, it's the folks in the community that frequently lead these movements. And really, we're talking about social movements that are demanding for human rights, social justice to happen, and it's these movements that are frequently help those who are making decisions realize the importance of making some changes happen to promote more equity. And this is part of I think the vital component of making change and moving forward is engaging with community, and while we also have academicians and government working together to make the changes possible. And so that's why I think it's so important to continue in all the work that's possible, that we sort of help, that we work with communities to define the problems, as well as those responses that are more likely to be sustained and address the important substantive issues involved.
Yeah, I would just add on to that, really. The work that we did is based on 2 years of dialogue across the European region with policymakers nationally and locally, with NGOs, with networks of NGOs, with youth and professional associations, with politicians. To basically, I mean, we had a goal to be able to start a conversation about this, but also to surface what were the barriers and to use our data to be able to address some of those barriers. And it started at the same time that the data collection was going. And I can show you some very nice examples. So, for example, the social platform is a European platform of more than 150 NGOs. They exist purely to support people to get ahead in life. Providing them with new opportunities for both not just civic engagement, but in terms of employment and stable income. So it includes a lot of social economy organizations, but they are organized politically to have a voice on these things at the European Union level. So that's a really good example. And if you, the social platform have been really quite significant in shaping the social charter and the social values that are now part of the new EU European strategy. Now, that might not mean anything if you're at the other side of the world, but what that means is every single member state signs up to that charter. They're monitored on it. Budget flows towards it. There's accountability linked to it. So here's an organization that has actually been really strategic in that, particularly around what I would say more around the income poverty side. Another organization that's playing a huge role in this area is the International Youth Health Organization. And they are playing a role as and building advocacy and building civil capability of young people to have a voice for themselves in political and policy decision making, but also to shape the futures that are right for all types of young people. If I give you an example of the kind of thing that they've done, they set up something called the Youth Health Card. We all know that today who you know, how much money you have, defines in some ways, right or wrong, the opportunities you have. And those opportunities define for you at a young age what your opportunities will be in life in terms of health, well-being, and in terms of the social determinants, your housing security, your income security, your job security. The Youth Health Card, they developed. They got 15 governments across the region, so that's a third of the governments across the region to pay for this, to give every young person the opportunity to participate in personal, cultural, social, and economic activities that wouldn't normally be able to do. So here's a good example of how both we're having dialogue and we're engaging. They are part of our new Health Equity Alliance because they're already in the field working and making this happen. So maybe I'll just stop there.
Yeah, just to add, I agree with what Chris was just saying, and that the power of community is extremely fundamental to change, because many times those folks who are elected are influenced by special interests with deep pockets, who have a vested interest in not changing the system in any significant way that may reduce the benefits that they're receiving. And so that's why it's so important that we work and we work with community as we move forward.
So there's a number of questions that are, I think, somewhat related to this issue, and I think so one of the ones that has come in is you know, in the U.S. and I don't think this is limited to the U.S. at all, but we seem to have the problem of a political system that responds to the wealthy and not the populace. How have you seen this type of inertia and resistance move to effective health equity policies that may not benefit the rich? I don't think that's an issue limited to the United States. What examples have you seen in your regions?
One example that comes to mind that I've been involved with here in California in the past is addressing the access to firearms, and in the process of doing that, we found that the community was very much unified in their concern about the dangers of firearms and potential dangers of firearms, and so communities were focusing on some of the most dangerous types of firearms, like the handguns and what were called Saturday night specials. And so in a number of different communities up and down California, they were passing these bans on Saturday night specials. And eventually, these communities got together and they moved towards Sacramento, the capital of California, to pass a law so that statewide, this policy towards reducing the access to these very inexpensive but also dangerously made firearms would be banned happened. And that in spite of all the challenges against them. And so that was just one example of how communities working together from a local and then expanding to statewide and regional can make a big difference and can implement policies that many people might not think is possible.
Yeah, and I'm just picking up on that. I mean, maybe just the two strands I'd like to bring in, and also looking at the chat. First of all, we did a review of public opinion polls across the European region, and we produced a very nice report on this, which has had huge mileage. On the one hand, I showed earlier the slides which said, look, in 4 years, with these interventions, which you already have in your policy portfolio, by the way, but they're not in tune to equity, you can deliver these gains. So let's get over this thing that inequalities can't be tackled in my lifetime as a politician. That's the first thing, because here's the evidence, and you can do it, and you can afford to do it. But if there's no pressure from the public for politicians or accountability to the public, politicians won't necessarily do it even if they have those solutions. So essentially, with the public opinion report and the work that we've done with that was about bringing forward the findings that actually 84% of the general public think that their governments aren't doing enough around health equity, and that this should be the top of their agenda. So when we're putting these things together, it's very difficult to let a politician off the hook. But what I would also like to do is to say, we use the data also to show the pathways between the investments that have been made in different socioeconomic determinants of health over the last 10 years, what impact that's had on these essential conditions or people's exposure to these risk conditions and its impact on health. So we've been able to show the pathways for the very first time between the policy decisions and the investments, how that has increased people's exposure to risk conditions, and how that directly is impacting on the trends and status and health inequalities. And when we're working with countries in this way, we're being able to say the decision that you made there to open up the market, to deregulate employment contracts, has had this effect over this time. And we're able to then model not just the effect for the health sector and for the people, we do that, but also to model it in terms of GDP, in terms of inward investment, in terms of prosperity, in terms of financial stability. So these are the things that we are finding, that there's not one message or way to do it, but you need to use your data and mine it richly to be able to get into that. And also you have to then be able to say, but here's how you can change that. So one is, here's a problem, this is the reason for it, but these are the things that you can do now, and they'll give you results there, and the public wants it. I hope that kind of explains some of the way that we're working.
Yeah, thank you. So I think we have time for just one more question, which is too bad. There's so many questions that have come in. It's really wonderful. So there have been a couple of questions about rural communities. So one of them is, in rural communities, are there programs created to provide access to health and health care? And what are some of them? And how are you thinking about issues that might be unique to those populations? And a related question is, have you observed any emerging best practices in rural areas that go beyond telemedicine, for example?
That's a great question.
Whoever would like to start, yeah.
That's a great question, and that's also a question, an issue in terms of the rural-urban sort of differentials or disparities, you might say, in terms of access to care. It's not just in the U.S., but it's many other places in the world as well. And I have to say that there are sort of many different sort of health systems that serve rural areas in the U.S. and in other countries, but far fewer than what is needed, without a doubt. Some of the efforts that have been done, besides the telehealth that was mentioned, is to actually work to provide opportunities for people who are from those areas to become health professionals. And because then if we sort of reach out and provide more opportunities for them to be health professionals, they who come from those communities are more likely to go back to those communities. That's where family members are. And so that provides a model where folks who come from certain communities that are underserved are reached out to, provided opportunities to move forward, and then to come and serve those communities ultimately. Those are models that can be helpful. Not all people will go back to rural areas, but I think it provides at least those folks who have many different factors and incentives to make that happen, and ultimately make the solution be homegrown.
Yeah.
Yeah, I mean, I think that's a really great kind of example, and I think we can see some of that happening definitely here. So when I look at countries like, say, Slovakia or Serbia or Sweden, they're all employing these kind of measures because they have got very rural populations. Macedonia is another example. The other incentive that seems to work here, and it's been institutionalized in quite a number of countries, is that anybody qualifying, whether it be a community nurse or a dentist or a pharmacist or a medical practitioner, has got to spend some time, like they do in Australia, in rural areas, so that there's a regular supply of, and this is important, regular supply of good quality, most recently trained people going to those areas, so that it's not just about getting any old person there. You know, it's fine to send somebody who's, like, you know, been a doctor, retired for 10 years, but isn't necessarily up to speed. Why should those people who are left behind or in rural areas not have the best care? So this is being implemented in quite a number of countries. But I think that one of the most innovative that's now being scaled up is in Ireland, and it's the men's health sheds. And this is for a population group who, yes, in rural areas, but even if they're in urban areas, they don't use services. So it's delaying seeking services to a point where when they do the etiology of the disease is further developed, and therefore the survival and the treatment is more, invasive. And the Men's Health Shed recognized that men, if you go to places where people meet anyway and you design your services around that, you not only get the health intervention delivered, but it creates this other health well-being environment. So in Ireland, where they have the Men's Health Shed, and now I think there's something like over 150 Men's Health Sheds, we can see that the social literacy, the well-being, the engagement, the sense of belonging, the motivation, and then the sense of agency to be able to take more control over their life, including their health choices and decisions, let's say, and that might be health-seeking behavior, has improved. And it's like improvements at up to 77% improvement in all men. So it's not just a small improvement. This has been built into the National Strategy for Men's Health in Ireland, and they deliver men's health services to vulnerable men only in this way.
Yeah, I agree with what Chris is saying. And throughout Latin America, this is the norm. When people finish their professional training, they spend a year in an underserved community. Many of these underserved communities are rural, but also many of them are in urban areas, particularly those urban areas that are low income. We know, and we certainly see it here in Los Angeles, those places that are low income have the least access, and those that are, as opposed to those areas that are higher income in urban areas. And so really, it's creating a whole system approach. Again, having people embedded in communities where there's high need, and then those people, again, are also, many of them likely to stay, or some of them stay to work there, but there's also a continuous flow of folks, and a commitment, a social commitment to do this work, and that this is important to address the needs of everybody.
Well, thank you. What a great discussion. I feel like we could go on for at least another hour or two or days. And what great questions from the audience. Thank you all so much. So just, maybe a couple of closing thoughts. Like the U.S., countries around the world have histories of colonialism and oppression that have left legacies of inequity with impacts across health as well as education, housing, income, and so many of the other social factors that we discussed today. And each country is working to address health equity in different ways. Although today we've obviously identified some common threads and found, I think, a lot of inspiration for our own efforts here in the U.S. I hope you've enjoyed today's conversation. I know I really did, and that you came away inspired and with a few ideas of how to take action on health equity in your own community. So let's continue the conversation. Please look for an email with a recording of today's discussion, and we hope you'll share it with everyone you know. I also want to encourage you all to sign up for funding alerts. Later this month, we'll be releasing a call for proposals aimed at U.S. cities. We're hoping to hear from city leaders, including public health officers, city planners, and others who are taking action on the issue of climate, health, and equity. And we're eager to learn from cities abroad. So please sign up so you know when that's live. So with that, I want to say a huge thanks to Chris and to Michael and to everyone who joined us today. We have a very short survey for you. Please fill it out. Please wash your hands, stay well, and I hope to see you all on our next Reimagined in America webinar. Thanks so much.
Thanks, everybody.
Bye-bye. Thank you.